Good afternoon. I'm Jennifer Murphy, your webinar host. Thank you for joining today's educational webinar with Global Partnership for Telehealth titled Infectious Disease Telemedicine with Dr. Vivek Manikal. As a reminder, we will spend a few minutes answering questions at the end of the presentation. Please type your questions in the Q&A box located at the bottom middle of your screen, and Dr. Manikal will answer your questions. For those of you interested or in need of continuing education hours, this webinar offers a free 1-hour CEU credit through the University of South Alabama Office of Continuing Medical Education, to which you may obtain after completing the survey that will be emailed to all in attendance. For those not in need of CEU credits, we ask that you also complete the survey, as all feedback is much appreciated and helpful when planning future webinars. I want to also welcome you to join us next month on June 24th as Valerie Morrison presents Best Practices in Telehealth Workflow, Lessons Learned on the Fly. You may register for this webinar as well as other upcoming webinars on the GPT website under the Media tab. Before we get started, I'd like to share a little information with you about GPT. Global Partnership for Telehealth is a nonprofit telehealth organization with a focus on consultative services, turnkey hardware solutions, and our easy-to-use telehealth platform, Pathways. Our organization was founded in 2004 to build a telehealth network in the state of Georgia. That quickly evolved into our current mission to leverage telehealth technology for the benefit of all. Our mission is to enable healthcare everywhere with the solutions we offer and our values of integrity, expertise, passion, and innovation. Be sure to follow Global Partnership for Telehealth on Twitter, Facebook, LinkedIn, to stay up to date on our webinar series, as well as other important information as we continue to leverage telehealth across the globe. At this time, I'd like to introduce our speaker and presenter for today, Dr. Vivek Manikal. Dr. Manikal completed his infectious disease fellowship at SUNY Downstate Medical Center in Brooklyn, New York. He then went on to complete his critical care fellowship at Mount Sinai Medical Center in New York, New York, before moving to St. Augustine, Florida. He has been providing quality healthcare in Northeast Florida for over 17 years. Dr. Manikal saw a dire need for medical specialists in rural communities when he worked in a rural area in Northeast Florida and started providing telehealth services to numerous rural Georgia hospitals and public health clinics. He is also the chairman of the Infectious Prevention and Antimicrobial Stewardship Committee at Flagler Hospital in St. Augustine, Florida. Here he saw the importance of decreasing the overuse of antibiotics within the hospital. He found that by implementing and maintaining antimicrobial stewardship principles in every patient encounter, he can help decrease the improper use of antibiotics and over time help decrease antibiotic resistance. Before I welcome Dr. Manikal, GPT would like to learn a little more about our attendees. I'm going to launch a quick poll and give you some time to answer a few questions. Okay, you should be able to see that poll. If you will, just go ahead and answer those questions real quick. I'll give you a few more seconds. Okay, I think everyone has hopefully had the opportunity to answer those poll questions. So now I would like to welcome our speaker and presenter for today, Dr. Vivek Manikal. Dr. Manikal, thank you so much for being with us today. And at this time, I'm going to hand it over to you.
Hello, folks. This is Dr. Vivek Manikal, and I'm the president of Infectious Diseases Telemedicine Providing Company, Coastal Telehealth Specialists. We are located in Northeast Florida, and I appreciate the opportunity to give you this presentation about infectious diseases telemedicine. With that, let's get going. What are the learning objectives of this webinar? Basically, we want to verbalize the potential of infectious disease telemedicine in diagnosing and treating patients with acute infectious diseases, verbalize how telemedicine consults bridge the gap between patients in remote areas and infectious disease specialists, no matter where they may be located, verbalize how infectious disease telemedicine can assist in infection prevention and antimicrobial stewardship programs, which are now mandatory, and verbalize the challenges in implementing an infectious disease telehealth program. When we talk about telemedicine, generally this is to provide care to patients in rural areas, and therefore I'd like to begin by talking about some aspects of rural healthcare that drive the implementation of telemedicine. There is a shortage of all specialists in rural hospitals. Only 30 specialists per 100,000 residents in rural areas, compared to double or triple that in urban areas. Rapid developments in the field of infectious diseases, especially new diseases such as COVID and so on, but also advances in the types of antibiotics and diagnostic testing that is available to physicians, which makes it very hard to keep up with the science. And therefore, primary care doctors are often unable to manage complex cases with the latest and greatest of diagnostics and antimicrobial therapy. Limited workforce and high reliance on locum tenens, leading to turnover, and of course, federal regulations and penalties. For example, catheter-associated urinary tract infections, CLABSIs or central line-associated bacteremias, Clostridium difficile infections, and so on. What are the challenges of rural healthcare before the pandemic? So there were obstacles faced by healthcare providers and patients even before the pandemic, and they are vastly different than those in urban areas. Rural hospitals treat patients with numerous comorbidities such as diabetes, coronary artery disease, IV drug abuse, and these rates appear to be higher than urban areas. These patients have a high infection risk even if they are admitted for non-infectious reasons. There are very high rates of bacteremia, tuberculosis, AIDS with opportunistic infections, sepsis, UTIs, hepatitis C, and more recently, just an explosion of patients with diabetic foot ulcers, which are, of course, complicated cases with Charcot foot, with peripheral arterial disease, gangrene, and so on. Many of these complex cases are hard to manage in a smaller facility and may need transfer, which is where an infectious disease specialist provides particular benefit to avoid unnecessary transfer out of the facility. Rural communities also have more uninsured residents and higher rates of unemployment, leading to less access in care, and therefore leading to patients coming in at a higher complexity of illness and in later stages of their illness. I'd like to talk about the IV drug abuse epidemic, if you will. And this has been going on for quite a few years, easily more than a decade. And initially, this was something that used to be seen in the 1980s and 1990s in inner city hospitals, Detroit, New York, Chicago, and so on, but now has spread everywhere in the United States, including rural areas, unfortunately. If you look at the male versus female preponderance, you will see that there has been a 100% increase in females shooting up drugs. And as far as the age is concerned, most of the patients are young. 18 to 25, you see a 109% increase. Some of these statistics are slightly older, but going forward, and what I've seen since 2013 till 2021, these numbers still apply. If you look at the annual household income, there has been a substantial increase across all income categories, which is quite alarming. So this is not limited to only people affected by poverty and low socioeconomic status. As far as the health insurance, unfortunately, many of these patients have no coverage at all, which makes it very hard for a healthcare facility to treat these individuals. Heroin addiction. This has been the cheapest opioid to abuse, and next only to fentanyl. And there has been a massive increase in heroin-related overdose deaths because of how easily the drug is available. If you look at these statistics, very alarming. This is a more recent slide. And synthetic opioids, other than methadone, primarily fentanyl, accounted for tens of thousands of deaths in 2019 and increasing quite alarmingly. After that, if you look at the data here, you see that the synthetic opioids are the king of abuse, followed by other opioids, prescription drugs such as semi-synthetic opioids and methadone. Heroin has been increasing greatly. Benzodiazepine increased slightly and leveling off, and cocaine in particular. Methamphetamine is also extremely popular and very dangerous, especially when used intravenously. So with that, let's share some cases that I've seen in rural facilities. And we start with a patient with intravenous drug abuse. Many of these patients come in extremely ill in emergency rooms and clinics across the, especially in rural areas. This was a 36-year-old female admitted with fever and chills, history of recent IV drug abuse with methamphetamine. The patient was bacteremic, multiple positive blood cultures for Staphylococcus aureus in September of 2017, September 26th, 25th on the date of admission, 26th, 27th, and the 29th. So in other words, she had sustained bacteremia with an organism that causes endocarditis. The echocardiogram showed a large tricuspid valve vegetation of about 2 centimeters. And with that size vegetation with an infection on the valve, cardiothoracic surgery was called in. But because the patient was a substance abuser, they declined to operate. A CAT scan of the chest was done, which I will put up those images in just a second. Patient had multiple bilateral nodular densities with cavitations, also known as septic emboli. Patient was started on vancomycin due to a severe penicillin allergy and rifampin. Subsequently, the blood cultures on October 1 were negative, and the patient appeared to be responding well to treatment. This is a video of the tricuspid valve with the vegetation on it. And this is the CAT scan showing bilateral pneumonitis, and especially in the left lung, you can see some cavitary and nodular densities caused by embolization of bits and pieces of the large vegetation from the tricuspid valve into the patient's lungs. So many of these patients do not like to stay in the hospital once they feel better, either because they are withdrawing or many of them are young patients. They just do not make the right decision when it comes to their own care and treatment. This patient unfortunately signed out against medical advice, but did agree to come to the infusion clinic for daptomycin, which is really not optimal because of lung involvement, but that's all they could do at that time. The patient failed outpatient daptomycin due to an allergic reaction and required readmission. Subsequent blood cultures remained negative. Vancomycin therapy was resumed, and she decided to stay in the hospital this admission to complete 6 weeks of IV antibiotics till November of 2017. This is a patient with drug addiction who was bitten, and you can see a linear scar of the bite wound somewhat healing up at the bottom, and then the patient has a secondary infection that spread around it. Infectious disease specialists are often called to evaluate patients with rash and skin lesions. So we do become sometimes the dermatologist for the hospital if they don't have someone who can make hospital rounds and see patients as an inpatient. This is a patient with pyoderma gangrenosum, which is a feature of patients with inflammatory bowel disease. Really not an infectious condition per se, but the ulcers can be quite large and often get secondarily infected. This patient has some yellowish slough and some darker material at the wound base. and probably needs aggressive wound care. The chronic changes around the ulcer itself are non-specific and do not necessarily signify infection. This is a patient with septic shock or very low blood pressures associated with severe sepsis. And due to the vasopressors, what has occurred is some severe vasoconstriction, basically resulting in digital gangrene. And you do see a rim of tissue at the base of each toe, which means the body has formed something called a line of demarcation, which allows the body to then subsequently auto-amputate, or in other words, there is a nice region of healthy tissue, and at its junction with unhealthy tissue is where the body just loses the digit at that point. Often these days that is performed electively as a surgical procedure to amputate at the site of the line of demarcation. This is a patient with IV drug abuse, infected venous access site or injection site, if you will. And typically this is the elbow region or the elbow vein called the antecubital fossa. This is a patient with herpes zoster of the arm, vesicular lesions, and very easily treatable with acyclovir. Now, rural hospitals are not spared from multi-drug resistant pathogens. Unfortunately, just because the facility is smaller doesn't mean they do not see patients with very drug-resistant bacteria. And this is an organism called Pseudomonas aeruginosa, and you'll see that on the left side of the slide. It is a sputum culture, and it says scant growth, which means there's not much of this organism. We talk about this in a little while again when I talk about infection prevention and multi-drug resistant organisms. But this is, again, a nasty bacteria, a newer cephalosporin combined with tazobactam or a beta-lactamase inhibitor called Zerbaxa is the only antibiotic that is susceptible for this particular organism. And that's what we would have to use to treat this if we decided that it was worth treating, because a lot of these germs are often colonized where they are just present but not causing infection. On the right-hand side, you can see a list of all the antibiotics that would otherwise work for Pseudomonas, which have now become intermediate or resistant. The R stands for resistance or resistant, and I is intermediate. And all those numbers are the minimum inhibitory concentrations. So again, rural hospitals are not spared their share of multi-drug resistant organisms, which makes treatment very expensive and sometimes difficult, if not impossible. So antibiotic resistance threatens everyone, and these are antibiotics that were released and what happened with them as far as the resistance genes and at what stage after they released they became germs became resistant to these antibiotics. For example, vancomycin released in 1958, and it has withstood, in my opinion, the test of time. There is vancomycin resistance, but clinically we don't see a whole lot of that in community hospitals, although VRE, or vancomycin resistant Enterococcus faecium, has been a significant problem in some hospitals. Vancomycin resistant Staph aureus has also been identified about 19 years ago. At the bottom of this table, you have imipenem, which was released in 1985, which is a carbapenem, and germs have become resistant to this particular class of antibiotics, which is a huge problem these days in many hospitals. For example, Klebsiella can form a carbapenemase and become resistant to it, and it's called a KPC, identified in 1996. Ciprofloxacin, identified in 1987, cipro-resistant gonococcus or Neisseria gonorrhea, identified in 2007. And there is the same issue with antifungals such as fluconazole and caspofungin, with Candida developing resistance, which makes it very hard to treat. What about Clostridium difficile? This is a type of colitis or bowel inflammation secondary to displacement of colonic microflora. microbiome or the normal bowel flora. Essentially, you take antibiotics for something else like a tooth infection or pneumonia or a sinus infection, and it kills all the good germs in your gut. The next thing you know, you have a flare-up of the spores of C. diff that resides in about 5% of normal individuals, but also can become rapidly colonized in the hospital just by being hospitalized and by giving broad-spectrum antibiotics. There are about 500,000 cases per year and more than 15,000 deaths per year in the United States alone. Other drug-resistant pathogens or MDROs, MRSA, ESBL, Klebsiella, and E. coli. CREs, essentially carbapenem-resistant Enterobacteriaceae, for example, your KPCs, and carbapenem-resistant Pseudomonas. Small and critical access hospitals have not been spared the problem of antibiotic resistance. And there are millions of patients every year identified or infected by an organism that cannot be treated by the recommended antibiotic. And there are about 35,000 deaths per year related to multi-drug resistant pathogens. How about COVID? So this is a CAT scan of the chest in a patient with SARS coronavirus 2 infection. And you see the ground glass opacities or this crazy paving pattern in a patient with severe COVID-19 pulmonary involvement. The patient is a middle-aged male who came in with lightheadedness, presumably due to hypoxemic respiratory failure. This is a chest CT scan, which shows the evidence of viral pneumonitis. The RT-PCR was positive in this particular case, and the patient was treated with the usual combination of remdesivir and steroids. What are the uses of telemedicine, especially when it pertains to COVID-19? So there are multiple waivers that CMS issued so that caregivers could easily provide telemedicine in an unrestricted fashion in a surge situation. So they had some waivers relating to the physical environment where you provide telemedicine. The CMS permitted non-hospital buildings and spaces to be used for patient care and quarantine sites. For example, a tent perhaps set up outside the emergency room, or perhaps in a parking lot where patients could be triaged. Telemedicine itself, they had a lot of waivers, making it easier for telemedicine services to be furnished to the hospital's patients. For example, non-HIPAA compliant software could be utilized so that patients could be quickly seen without necessarily incurring the expense and cost of HIPAA compliant software. Staff licensure rules were waived and relaxed, and CAH status and location issues were looked into, and also waiving the requirement regarding this community access hospitals off-campus and co-location requirements, allowing the community access hospital flexibility in establishing temporary off-site locations. The length of stay was also changed, and the length of stay be limited to 96 hours was waived. So the use of telemedicine with the COVID patient within the facility is basically to reduce provider exposure. That would be the use case scenario that makes the most sense. But one has to be careful about how we think about this. For example, if you have a nurse who is going from room to room and the provider is doing the telemedicine, then certainly that nurse's exposure has to be considered. It certainly would save PPE. One person was doing the telemedicine as opposed to multiple individuals using multiple types of PPE for each patient encounter. Dedicated COVID unit carts also are extremely useful, but again need to be taken from room to room unless there is a dedicated cart per patient, which can certainly increase the expense. And finally, setting up a telemedicine unit in each room itself would be the way to go, where the remote provider dials in, is able to see the patient remotely without the use of a telepresenting staff member, if you will, which saves time and can also save on the utilization of personal protective equipment. Outside the facility, there has been an explosion of home-based services. Certainly all the companies that provide direct-to-consumer telemedicine did extremely well during the pandemic, with patients being able to call in from their homes, get an opinion about their symptoms, have testing services made available to them where, with the direction of a remote specialist, get a COVID-19 test, and so on. This reduces patient and provider exposure, keeps the patient in their home, and reduces the spread of infection. Mayo Clinic has a very nice remote patient monitoring program for those with COVID-19. And this is applicable for patients who are both diagnosed and discharged to home from the emergency room or from a walk-in clinic, and also for patients who require admission and subsequently are discharged with perhaps home oxygen and so on. They use medical technology and devices that are sent to patients' homes. The most important metric for managing these patients is oxygenation. If there is a patient who is newly diagnosed with COVID-19, a pulse oximetry that can be easily done at home, showing a saturation of less than 94% on room air, is considered critical and requires referral to the emergency room. So what kind of services can be provided via telemedicine? The way we provide service is generally normal business hours, Monday to Friday, and depending on the hospital, if weekend coverage is required, that could be set up as well. Outpatient consultations can be done in the hospital's infusion center. Weekly IV antibiotic monitoring could be performed. Some of the more common inpatient diagnoses are AIDS with opportunistic infection, sepsis, ICU admissions and infections, and community-acquired infections such as pneumonia, urinary tract infections, bacteremias, diabetic foot infections, COVID-19, appendicitis, just about any infection that perhaps the family doctor or the surgeon or the hospitalist cannot manage. There are many surgical cases as well, including orthopedics, general surgery, urology, patients with prosthetic joint infections that require long-term IV antibiotics. Unfortunately, there are consultations for patients with nosocomial infections such as Clostridium difficile, MRSA, and so on. Multiple resistant pathogens. Sometimes these are just colonizations and not actually infections. And of course, intravenous drug abuse with bacteremia is also a common cause of consultation. Additional consulting services via remote conferencing can be done for infection prevention and antimicrobial stewardship, reviewing reports, and providing advice. Outpatient provider care model in the Mass General Hospital's cardiology division is something that all clinics can learn from. And basically during the pandemic, they went from a traditional model of clinic-based care replaced with team-based phone calls, synchronous video visits, asynchronous symptom checks, and at-home vital sign monitoring. I would suggest that you look at this flowchart in detail, and this is applicable to almost any outpatient setting in any specialty, not necessarily cardiology, which is why I've included this, and we have references to this article. So if you look at the sample clinical workflow, which can be amended to any situation, a new patient who has to be evaluated by telemedicine is first judged whether that patient is safe for a virtual visit. And what might make it unsafe, of course, if there is some emergency situation, that certainly is not a patient that could be evaluated via telemedicine, especially for the first go around. If the patient is deemed to be safe, is the patient amenable to a virtual video visit? And if the answer is yes, looking straight down, the patient receives a secure email with instructions on the virtual visit setup. And on the day prior to the visit, they receive an automated email with the visit link. Technical assistance for the patient to reach the virtual waiting room is provided on the day of the visit. and a Zoom virtual visit completed with the clinical provider. So that is pretty simple. And this is applicable to established patients as well. Now, what if the patient is not appropriate or safe for a virtual visit? An in-person visit can be scheduled if it's not an emergency situation, and the patient is contacted on the day prior to the visit for medication reconciliation and COVID-19 screening questionnaire. In-person visit is completed with the clinical provider on site. How about for patients who perhaps are appropriate for a virtual visit, but not really amenable to a virtual video visit? This might be someone who does not have good internet connection or is not savvy with the use of computers and so on. Are there any modifiable barriers to care? If you look at on the right-hand side of the slide, and if nothing can be changed for this patient, a telephone visit can be performed, which, as you know, many insurances, especially Medicare, are paying for these days. What about telemedicine for outpatient antibiotic infusion therapy? Patients are often discharged from hospitals on IV antibiotics. Occasionally, an outpatient is seen in the office that requires initiation of IV antibiotics. Telemedicine encounters can be done to initiate therapy and also follow these patients up once a week. Most common conditions are bacteremia, intravenous drug abuse, osteomyelitis, severe cellulitis, bite wounds. And again, the typical duration for this would be 2 to 4 weeks. A midline catheter or an extended IV catheter is inserted, and PICC lines are by and large avoided in these cases. Outpatient tests, including labs and x-rays, are done during the follow-up period.
Hey, I've got admission for you. Now, normally I would have ordered vancomycin just after looking at this guy, but we just had this talk from pharmacy on antibiotic stewardship, so I thought I would wait until the labs are back before ordering vancomycin. Actually, let me just refresh my page real quick. Oh, looks like we got a white count of 10.7. You know what? I'll go ahead and just order the vancomycin for you. In light of pharmacy asking us ED docs to be better stewards of antibiotics, I thought I would let you, as the medicine resident, do the honors of ordering the customary vancomycin. Yeah, this guy's pretty septic, but I know we're trying to limit vancomycin usage for some reason, so I just gave this guy half doses of each of them. Just trying to do my part, you know? Yeah, I think this guy might have COVID. He's got a high D-dimer, he's leukopenic, he meets sepsis criteria, so I think I'm gonna start him on... Honestly, I think this would be a good time for vancomycin. Don't want to miss anything, right? Gotta be a good antibiotic steward. Yeah, I was originally just gonna order Zosyn for him, but then I think I heard some nurses talking about MRSA in the corner, so I thought I would throw on some vancomycin just to be safe. What is a steward, by the way?
So what are some of the commonly misused antibiotics? We will answer that question by looking at the syndromic approach to antimicrobial stewardship. In other words, for a particular diagnosis, what are the commonly misused antibiotics and what can we use? So for community-acquired pneumonia and COPD exacerbations, fluoroquinolones are extensively misused. And one of the downsides of fluoroquinolones, other than the black box warning of tendon damage and so on, is a higher incidence of C. diff or Clostridium difficile with these antibiotics. For skin and soft tissue infections, third-generation cephalosporins and clindamycin are often misused in the hospital setting and also as an outpatient. Broad-spectrum agents in the hospital, such as piperacillin tazobactam, also known as Zosyn, vancomycin, cefepime, are significantly misutilized or overutilized. And instead of that, simple antibiotics such as cefazolin or ampicillin sulbactam could be used for cases of straightforward skin and soft tissue infections without deep abscesses, without osteomyelitis, or mixed infections such as a diabetic foot infection. In intra-abdominal infections, vancomycin is often used. It is generally not indicated. Carbapenems often are started up front when they are not required, and other antibiotics such as piperacillin tazobactam or a cephalosporin with metronidazole could well be utilized, specifically a third-generation cephalosporin with metronidazole. With urinary tract infections, Again, unnecessary treatment of asymptomatic bacteriuria is a problem, and overuse of third generation cephalosporins and fluoroquinolones is a major problem because of induction of resistance enzymes and Clostridium difficile. So what are the antibiotics that one could use for a simple cystitis? If they have no allergies or renal issues, nitrofurantoin or Bactrim could easily be utilized. Fosfomycin is a one-time dose type of antibiotic that is commonly used for cystitis. Unfortunately, for pyelonephritis, some of these antibiotics may not be useful, and we also have to think about drug resistance. Bactrim can be used for both prostatitis and for pyelonephritis, but unfortunately, a lot of the bacteria these days are resistant to sulfonamides. Going on with antimicrobial stewardship, what are the things that can be implemented in a hospital setting? What are the requirements for a program? So the core elements are, the first thing is a leadership commitment. In other words, having somebody who can lead the program, but also dedicating the human, financial, and information technology resources. Accountability, and that may be on a physician level or a pharmacy level. Drug expertise. Now, this typically comes from pharmacy, but also from an infectious disease specialist. And finally, action. In other words, what are the actual activities that will be performed on a daily basis to actually halt an antibiotic that appears to be inappropriately prescribed? For example, antibiotic timeout is a very common action that is performed with stewardship. The patient and the doctor is allowed to prescribe an antibiotic for that patient for, say, 48 hours. But after that, if it seems unnecessary based on the cultures, a note or a phone call is generated, the physician is requested to act with the gentle suggestion to stop the antibiotic unless they feel that it is clinically still warranted to continue. Other parts of the stewardship program are tracking, because if you don't monitor data, you really won't get anywhere, especially establishing a baseline antibiotic usage and then comparing it with national standards and internal usage data as well. Monitoring resistance patterns, and that occurs in conjunction with the local microbiology lab. And finally, having IT support to back up the program for adequate reporting is absolutely essential. Regular reporting includes information on antibiotic usage and resistance, and providing feedback to the doctors, nurses, and relevant staff about antibiotic usage, overuse, and its implications. You will find some information about stewardship, antimicrobial stewardship for critical access hospitals on the CDC's website. A remote consultation with the telemedicine infectious disease specialist could be done as an off-site expert, if you will, to give guidance regarding antibiotic usage. And this can be perhaps talking to hospitalists and also to the pharmacists about antibiotic usage in a particular case or in general. So switching to some challenges of providing telemedicine. Those are the 3 Ps that I refer to with some additions there. So the first one is patients and facility. Patients may be reluctant to use telemedicine. They see it as a doctor on a phone or a doctor on a video. How can that be? How can a physician who isn't examining me provide actual care? That could be one challenge or one negative factor. Of course, patients may have some issue with device operability, connectivity, and that applies to hospitals as well. Poor internet connection is certainly a very bad way to begin a telemedicine consultation. Providers, they may be reluctant to consult a telemedicine specialist due to various reasons. Some of them might just prefer an in-house physician. They have questions about quality, safety, privacy, accountability after these consultations are performed. And then finally, payers and regulation and reimbursement laws and regulations need to be considered as well. This is a slide from a CMS website, and basically talks about Medicare telehealth reimbursement. If you look at the codes that are available, there is a link there within the slide for a complete list. And they have maybe more than 200 codes that Medicare covers as far as telemedicine reimbursement is concerned. For Medicare telehealth visit, it has to be a telecommunication system between the provider and a patient. The common telehealth services codes are the 99201 to 215 codes. The office, or these are office or other outpatient visits. The G425 to 427 are inpatient telehealth consultations, and the 406 to 408 are follow-up consultations to beneficiaries in hospitals or skilled nursing facilities. These are the commonest codes that I use when I perform consultations, and I simply do not have the time to keep up with all the changing codes. So it's pretty much consultations and follow-ups is what we look at. But depending on the type of practice, you are welcome to look at the complete list of codes and see what might work for you, and talk with your billing company to make sure that these are indeed covered by your local Medicare contract. Virtual check-in. This is not really something I use, but it may work for certain types of practices. And a brief 5 to 10 minute check-in via telephone or other telecommunication device to decide whether an office visit or other service is needed. So again, you have to sit down with your peers and your billing manager and decide if this is something that you really want to start doing in your office. E-visits, various codes are listed here. These are for established patients. What about some of the laws related to telemedicine? As far as, the other reimbursement issues related to telemedicine, each state has their own laws. Alabama requires live video. Store and forward is not reimbursed for Alabama Medicaid. Remote patient monitoring is covered, and so on. In Georgia, you see that live video is covered, store and forward is covered as well, and remote patient monitoring not covered. I believe this data was taken at the end of 2020. Private payer laws, including payment parity laws, exist in Georgia, and consent is certainly required. Even if consent was not required in a particular state, out of an abundance of caution, I would still get signed consent to the extent possible. What about facility issues and hospital issues in the coverage of telemedicine and provision of telemedicine services? Electronic medical record access is certainly an issue, where the remote specialist may have to log into multiple different EMR systems and document within those systems. And that could be extremely challenging when you have to deal with multiple different EMRs and becoming familiar with them. Lack of other supporting specialists. So you may do everything you can to improve a patient's outcome, change the antibiotics, but they may still require transfer because of lack of a particular surgical specialty or interventional radiology or orthopedics, and so on. Reimbursement, to the extent that some of the care may not be covered by insurance, that is something you would have to figure out with the hospital, some sort of reimbursement for the provision of care to the inpatient, which essentially you are doing to help the facility and the patient, but may not be reimbursed because of denials from the insurance companies. And there are, of course, high rates of uninsured cases in inpatients, sometimes 20 to 25%. You would have to figure out some contractual matters with the hospital to get reimbursed to provide those kind of services to uninsured patients. So who is our technology partner? Essentially, the Georgia Partnership for Telehealth. We use off-the-shelf software and stethoscopes The software was developed by Georgia Partnership for Telehealth, GPT Pathways, really an excellent software which works very well both in the office setting, directly to the patient's homes, but also to hospitals. We use a stethoscope to listen to the heart and lung sound. So it's really a full patient examination. A well-trained telepresenter is indispensable, and generally they should know what kind of an examination you're looking for, and that always helps to complete a thorough and full physical examination. Here are the references. I'll let you read over them. The references include the TikTok video, so I'll let you enjoy that again if that's what you want to look at. And then finally, I'll leave the floor open for questions. Thank you very much.